How's it going, guys? Past level question, endocrine, MSK, step 1, internal medicine, TCK. Before we get started, please subscribe to my channel. I really appreciate it. Give you a like, really appreciate it. Find me on Instagram, Mehlman_medical, MEHLMAN_medical, links down below for me, Telegram. Links to the Telegram group and channel down below. And start the clip. 64-year-old woman, type 2 diabetes, hypertension, managed with metformin, lisinopril, blood pressure 135 over 85, serum creatinine 1.2, urinary protein 1 plus. Her PTH and calcium represented on the graph here, and you can see that the magenta dot is in the normal box, so her PTH, calcium, both normal. Question wants to know most likely diagnosis. Let's just hop to the answer choice here. Choice A, early renal insufficiency, wrong fucking answer. Creatinine is normal. Normal range 0.7 to 1.2. Renal insufficiency by definition would mean that you have an increased creatinine, which we clearly don't. Now, of course, the patient has risk factors for renal failure eventually, diabetes, hypertension, but in this situation, we don't have renal failure. Exceedingly high yield, you know that for renal insufficiency, our dot is going to be in the top left, low serum calcium, high PTH. We call this secondary hyperparathyroidism. There's two reasons why calcium is low in renal failure. The first is calcium is normally reabsorbed at the late DCT, and we can't do that. So calcium is going to be low in the blood. The second reason is PTH normally activates 1-alpha hydroxylase in the kidney, which converts in the PCT, which converts to inactive 25D3 and active 125D3. The latter goes to the small bowel, causes calcium absorption. So if we can't do that, we're getting hypocalcemia. Decreased negative feedback at the calcium sensing receptors, the parathyroid glands. Parathyroid hormone goes up. It's called secondary hyperparathyroidism. Dot is in the top left here, exceedingly high yield. Likewise, you need to know osteomalacia and rickets. Dot is also in the top left because if we have vitamin D deficiency unrelated to renal failure, we're simply going to have decreased calcium absorption in the small bowel. And that, of course, decreased negative feedback, parathyroid glands, PTH goes up to compensate. Wrong fucking answer. Choice B, metastatic malignancy, wrong fucking answer. That would be in the bottom right here. Okay, it's exceedingly high yield. You know for USMLE that calcium's high, PTH is low. Metastatic malignancy, one of the most important causes of hypercalcemia. Metastases will go to bone, cause a cytokine effect, and that's going to cause calcium to leach out of the bone and increase negative feedback at calcium sensing receptors, the parathyroid glands. PTH is suppressed. Now, not just metastatic malignancy, but it can also be squamous cell carcinoma of the lung, renal cell carcinoma, secreting PTHRP, okay? Which it's not the same as endogenous PTH, so we'd have high calcium and then PTH would be suppressed. USMLE can be real fucking slick with how they do this. They don't even have to write metastatic malignancy. They can just write lobular carcinoma of the breast, or they can write ductal carcinoma, invasive ductal carcinoma, and you just need to know that it means it's metastasized because you'll eliminate to get there in that situation where the dot's in the bottom right and it's the only answer that would make sense. In this case, wrong fucking answer. Choice C, Paget disease, correct answer. It's the only answer here where the dot could be in the normal range. People think that there's some sort of derangement with Paget disease, e.g. something wrong with calcium. It's not the case. You're only going to see an isolated increase in serum ALP. 14 out of 15 questions. See one question where it's not the case. 14 out of 15 times, you're going to see an isolated increase in serum ALP, calcium, phosphate, PTH, all normal. So when we talk about bone, ALP activity reflects osteoblast activity. So we have mixed osteoblastic clastic phases in the bone, increased bone turnover. They want you to know that. They can give you a vignette of Paget disease, answer is increased bone turnover. It need not be an older male whose hat doesn't fit him anymore with tinnitus due to acoustic foramina narrowing. It's a buzzy presentation, doesn't have to be the case, just an elderly patient who has an isolated increase in serum ALP. All right, now I just mentioned a moment ago how ALP activity reflects osteoblast activity. That factoid is very high yield. There's a question on one of the new NBMEs where they give you some obscure neonatal craniosynostosis condition, and they say serum ALP is decreased, and they asked which cell is fucked up, and the answer is osteoblast. And I had a student DMing me about some weird syndrome showing up in the exam, and OMG, you need to know it. And I'm thinking to myself right away, there's always a bigger picture concept involved. They don't give a fuck if you know about some obscure condition. Students sent me the question, and I look at it, I'm like, boom, it's right there. They say right in the fucking paragraph, ALP is low, and I said to the student, I'm like, they don't give a fuck that you know about this weird syndrome. They say right there, ALP is low, and the bigger picture concept is you're aware that ALP activity is reflective of osteoblast activity. So if ALP is low, osteoblast activity is low. In this case, well, it's the correct answer. How you like that? Choice D, sarcoidosis, wrong fucking answer. So dot would be in the bottom right. Now, You've got non-caseating granulomas, sarcoidosis, where you're going to have activated macrophages called epithelioid macrophages, aka histiocytes, that are going to secrete 1-alpha hydroxylase, okay, classically in the pulmonary parenchyma. It's the same enzyme that you normally see in the kidney, but it's going to activate 25D3 and a 125D3 ladder going to small bowel, increasing calcium absorption. So our calcium is high, PTH is suppressed. They like that for USMLE. Classically African-American woman, 20s to 30s, and she's going to have red shins as well, sometimes dry cough, bihilar on a chest x-ray. In this case, wrong fucking answer. Choice E, tertiary hyperparathyroidism, wrong fucking answer. So you need to know that this is going to be a patient who has long-standing renal failure that has now been treated. Okay, so what they're going to do, I just told you at the start of this clip that in renal failure, we have secondary hyperparathyroidism, where the dot's in the top left. But let's say you treat the renal failure, e.g. through dialysis, calcium binders, etc., phosphate binders, etc. So let's say you treat the renal failure, and the calcium is now back in the normal range. But holy shit, PTH is still high. And you say, well, why is the case? Why is PTH not going down if our calcium is back in the normal range? It's because of parathyroid hyperplasia. Okay? So if we have parathyroid activation over a long period of time in the setting of renal failure, even though you've corrected the calcium now in renal failure, the PTH is going to stay elevated due to parathyroid hyperplasia. It's an answer on a 2CK form. I've only seen it assessed once. They just say, why is the PTH elevated in this patient? The answer is parathyroid hyperplasia. And then the explanation for that NBME question goes on to talk about tertiary hyperparathyroidism. In this case, wrong fucking answer. You know the deal. I'm going to make more content. If you like my stuff, subscribe my channel. Appreciate your time. That's it.